Good evening, colleagues. I'm Dr. Suzette Stander. I'm the president of the South African Society of Periodontology and Implantology and Oral Medicine. And it is my great pleasure to host tonight's webinar. So SASPIO, in conjunction with SADA, and the various periodontal departments of our various universities wanted during Oral Health Month to shed more light on the various conditions affecting the periodontium, implants, as well as oral medicine. So tonight, Dr. Michaela Beetge from the University of Pretoria will be giving us some more insight on empowering patients and students in periodontics, the 2080 rule, and effective patient education. But before I formally introduce our speaker of this evening, I would just like to go over a few formalities, just some future events for our colleagues to diarize. SASPIO speaker for the annual SADA meeting for 2025 in Durban will be Professor Lisa Hates Mayfield, who is a world-renowned periodontist, and she will be coming to lecture us on peri-implant disease diagnosis and management. It is from the 25th to the 27th of July 2025 at the Durban ICC, so please remember to diarize it. Then we won't accept any raised hands during the session. We will only accept questions and address it at the end of the webinar. And now I would like to introduce Dr. Michaela Beetge. She received her dental degree cum laude in 2008 at the University of Pretoria. She did a community service here in the Free State, in Paris. And then before she went in private practice, she was also part-time at the same time working in private practice, employed at the University of Pretoria as a sessional doctor. In 2011, she received a postgraduate diploma in aesthetic dentistry cum laude at the University of Pretoria. And in 2015, she completed her master's degree in oral medicine and periodontics cum laude at the University of Pretoria. Then in 2020, she received a fellowship in medical education and research at the Sub-Sahara Famer Foundation for Advancement of International Medical Education, Research and Regional Institute. And in 2024, this year, she received a postgraduate diploma in health profession education and leadership cum laude as well. She's a specialist consultant and senior lecturer at the Department of Periodontics and Oral Medicine at the University of Pretoria from 2016 until currently. She's got quite an impressive resume. But Dr. Michaela, thank you for joining us tonight. We are all looking forward to your webinar and we wish you the best of luck.
Thank you, Dr. Suzette, and thank you also for the nice introductions. I appreciate it greatly. I'm going to share my screen now, so just confirm that it is visible.
Yes, thank you, Dr. Michaela. We can see you.
Okay, thank you very much. So thank you for giving me the opportunity to share my passion with you tonight, empowering patients and students in periodontics. I'm going to discuss the 2080 rule and then subsequently effective patient education. Okay, the PowerPoint does not want to advance. Sorry. Okay, I'm struggling a bit. It did work. Um, can you see my screen now?
No, not at the moment. We can't.
Okay, let me just try this. Okay, I'm going to try again.
No problem. Yes.
Okay. Okay, perfect. Sometimes technology can get the best of us. So,
Perfect.
yeah. Can I ask the audience or the viewers to please scan the QR code? Or alternatively, you can log into the Mentimeter app by using the password as indicated. So once you have scanned the QR code, there will be 5 options, and I would like you to give your most honest opinion when selecting one of the options. The question is, I gave oral hygiene education 1 within this week, within the last 2 weeks, within the last month, more than 1 month ago, and then the last option is I don't give oral hygiene education in my practice. Okay, I see it is working because we have one response. I will give just a few seconds. It's quite active and nice to see. No one can see who is answering what. If you are concerned about that, it's totally anonymous. The last option is not saying that you don't give oral hygiene education in your practice. You can have someone else giving it and not you necessarily. So that is the option 5. Okay, I'm going to give another 10 seconds and then we can go on. Okay, so I think everyone can see that majority of the people in the room have given oral hygiene education within this week. It's quite interesting. I'm going to move on to the next question, so you can just scan it again. This question states, when I give oral hygiene education, it takes me approximately less than 5 minutes, between 5 or 10 minutes, more than 10 but less than 20 minutes, more than 20 but less than 30 minutes, or then the last option, more than 30 minutes. Do you have access to the poll? Okay, I'm going to continue, but obviously,
Yes, Dr. Michaela, I think when we scan this one, it just gives us the first question.
if you just go out and rescan it,
Okay.
you need to rescan the new QR code.
It still takes us to the last
And
question.
just the one question. Oh, never mind. But I think what is important here, even though we don't have the answers, is after this evening, I would encourage you to reflect on areas where you can maybe improve, and reflect also in areas where you think you're doing well. I think this is the whole idea of giving webinars such as this, is to see where we can actually improve or where we can actually provide help to another colleague. So the webinar outline for tonight is then I'm going to stand still and discuss why prevention is important, and also the importance of oral health in relation to general health. I think it's important to understand the concept of the biofilm and its role in oral diseases. We will then look at the 2080 rule, the Pareto principle in dental care, and specifically the clinician's role versus the patient's responsibility. The preventative strategies that we will discuss is mechanical devices, guidelines and behavior reinforcement, and then also chemical biofilm control. And then last but not least, we will highlight the importance of individual oral hygiene instructions. And I will also like to give you some of the some results of a study that we conducted on this topic. With today's topic, I want to shed light on prevention, which is the keystone in maintaining oral health. Patients want a healthy smile. This includes healthy gums, healthy teeth, and we know a healthy mouth means a healthy body. It is important to avoid issues, and for that, we need to take proactive care to prevent painful and costly treatment. Now, what is the biofilm? We associate disease with a dysbiotic dental biofilm. A dental biofilm is complex communities of microorganisms that interact with each other, but also with the host, which are structured in organized polysaccharide matrices and adhere to different surfaces in the oral cavity. Biofilms can adhere to soft tissue surfaces, but also hard tissue surfaces. When adhering to soft tissue surfaces, like, for example, epithelium, this biofilm gets shed more readily than when it's found on hard tissues, due to the fact that epithelium undergo a constant turnover or remodeling. Biofilm, thus, on hard surfaces are more matured and complex. An imbalance of good and bad oral bacteria leads to a dysbiosis and a subsequent disease. And by preventing the biofilm, we can keep the mouth in balance. This is a story, or this is something that really happened in my clinic not so long ago. It is based on true events.
Allow me to tell you a story that is based on true events.
Imagine this. A patient walks into my office. They've been referred to me because their teeth are loose, migrating out of place. The discomfort? Significant. Their concern? Understandable. As I sit with them, I dive into the examination and find the culprit. Periodontitis. A silent yet destructive disease that not only affects the mouth, but can have far-reaching effects on overall health. I begin explaining. I tell them what periodontitis is, how it's caused, and the risk factors: poor oral hygiene, smoking, even genetics. I talk about how it's not just about teeth. It's about systemic health. If left untreated, this disease can lead to serious complications beyond the gums. I outline the treatment: scaling, root planing, lifestyle changes, ongoing care. I share the reality. What happens if it's ignored? And then, the questions begin. So many questions. Thoughtful ones. Honest ones. The patient is genuinely engaged, eager to understand every detail. After a while, the patient pauses and apologizes for asking so many questions, thinking it's too much.
No need to apologize. In fact, it's good that you're asking. It shows you're taking control of your health,
But why didn't anyone tell me this earlier? Why did no one explain the risks before it got this bad?
This single question hits home. Why didn't someone tell me before? It encapsulates a critical gap in health education. How many others are out there, left in the dark, unaware of how something as simple as gum disease can lead to catastrophic outcomes for their teeth and overall health or suffering from other conditions that could be managed, treated, or even prevented? This is why health education matters. This is why we're here today.
And that's the heart of health education, empowering patients with the knowledge they need to prevent disease, make informed choices, and ultimately lead healthier lives. It's about time we stop letting patients ask, "Why didn't anyone tell me?" and start ensuring they know what it takes to protect their health every step of the way.
So oral hygiene is the practice of keeping one's mouth clean and disease-free by regular brushing and cleaning between the teeth. It is essential for maintaining oral and periodontal health and preventing diseases such as tooth decay, periodontitis, and related conditions such as halitosis. In a study published by Burkhardt in 2017, it was concluded that plaque is the forefront of proximal risk factors leading to periodontitis. Plaque is also associated with inflammation, especially periodontal inflammation, and it is a predictor of disease progression, treatment outcome, and disease recurrence. The factors affecting the oral hygiene efficacy is very important to consider. The patient motivation can be influenced by factors such as self-efficacy, knowledge, and support. Proper brushing and flossing techniques are essential for effective plaque removal. Patients with dexterity issues may require additional guidance and adapted tools. Consistency in oral hygiene practices is critical. Patients need to be motivated and understand the importance of following instructions. And long-term adherence to oral hygiene practices require a strong, motivated patient. It is worth mentioning that in patients with periodontal disease, oral hygiene is more technically demanding and also time-consuming. The Pareto principle was discovered by Italian economist Vilfredo Pareto in 1896, where he first realized that 20% of his pea pods in his garden were responsible for 80% of all the peas. Also, he discovered that 80% of the land in Italy was owned by 20% of his people. The Pareto principle is known as the law of the vital few, and it teaches us that there are a few things that are very important. Also known as the 80-20 rule, which means that 20% of causes create around 80% of the outcomes, or 20% of your effort makes 80% of your success. Over time, the principle became a valuable rule of thumb that allows our mind to understand all sorts of complex distributions, focus on the essential, and prioritize what to do next. For example, business owners of a company came to realize that 80% of the company's income comes from 20% of the customers. As a result, they know who to give special attention to. Also, another example, constructors find out that 20% of hazards results in 80% of the injuries. This will allow them to take important precautions and eliminate risks. This is only two of a lot of other examples. The 20-80 rule in periodontics is an informal guideline suggesting that 20% of the effort comes from the clinician, while the remaining 80% of the results depend significantly on the patient's involvement and effort to achieve optimal outcomes. In practical terms, this means that while periodontal treatment and maintenance provided by the dental professional are crucial, The patient's role in maintaining oral hygiene and following recommended care at home is equally, if not more important, for long-term success. The principle emphasizes the shared responsibility between the clinician and the patient to achieve optimal periodontal health. It also highlights the huge responsibility on us as clinicians to give the correct information. The key to success is treatment for prevention. The following approaches are aimed to improve the supragingival control. Mechanical methods, your modifying behavior and oral hygiene practices, and the chemical biofilm control. I will discuss these approaches according to the EFB guidelines. The articles that this information was gathered from is then from the 11th European workshop published in 2015, also from our 2017 workshop that EFB that sat together with ORCA, our treatment guidelines for stage 1 to 3 periodontitis that was published in 2020, and then last but not least, our treatment guidelines for stage 4 periodontitis that was published in 2022. So if you need to go and read a little bit further, these are the articles that you can refer to. Now, based on the EFB workshop and guidelines, there are statements that were highlighted, and please allow me some time to discuss them with you. First of all, rechargeable powered toothbrushes provide small but statistically significant additional reductions in gingival inflammation and plaque levels. Secondly, interdental brushes is the device of choice for interdental plaque control. And then thirdly, flossing is not recommended except for healthy sites where interdental brushes cannot pass through without causing trauma. Now, I want to highlight that the articles that I just showed in the previous slide, based on patients with periodontal disease that include gingivitis and periodontitis. So with regards to flossing, we will, and the interdental brushes, I will address that in a moment. Interdental brushes are the device of choice for interproximal plaque control. Like I said, I want to highlight that the consensus documents speak to a majority of patients with periodontal disease. But I also want you to consider that floss alone might not be enough. Yes, it cleans the mesial and distal line angles, but what about the embrasure space? This is where the interdental brushes might make a difference, but it cannot be overemphasized that we need to use it correctly. We need to show our patients how to use it correctly. Some companies do provide training if you feel that you need to be updated in this regard. So professionals should teach patients how to properly use interdental brushes, and clinicians may suggest other interdental cleaning methods when brushes are not appropriate. Then we move on to the dentifrices or toothpaste. The first aspect that we're going to touch on is the mechanical action. So there's moderate certainty that toothbrushing with a dentifrice does not provide an added effect for mechanical removal of dental plaque. What does this mean? The toothbrush is mainly responsible for the mechanical action of plaque removal. But what about plaque inhibition? So, weak inhibitory effect on plaque regrowth in favor of a dentifrice showed when it is used on a daily basis. There's also moderately good evidence that using an active ingredient dentifrice, such as triclosan copolymer or stannous fluoride, can significantly improve clinically the ability to inhibit plaque compared to using a regular sodium fluoride dentifrice. So in essence, toothpaste is not going to remove plaque in a mechanical way, but it does have an advantage to inhibit plaque formation. if it contains the correct active ingredients. Then I'm going to challenge the audience again with interdental cleaning devices with specific reference to the rubber interdental cleaners, also known as the rubber interdental picks or silicone-coated interdental picks. So there's weak to very weak evidence for plaque reduction in patients with gingivitis, as shown by Van der Weyden in 2022. But another author, Janine, 2022, showed that rubber interdental picks are more efficient than toothbrushing alone in reducing plaque and gingival inflammation. So now the question that I want to ask is, does it play a role in patient compliance? Clayton in 2008 mentioned that 12% of a Swedish adult population used floss in comparison to 46% that used wood sticks. If these rubber interdental picks ensures patient compliance, the question is then, is it then better than nothing? I don't have the answer for that. Toothbrushes, powered versus manual toothbrushes, has a small benefit, but it is significant clinically. Also, the oscillating, rotating mode of action showed moderate evidence for a very small benefit over the high-frequency sonic mode of action. Now, changing patient behavior. We can't do anything if the patient is not willing to change. Imagine driving down a familiar road and suddenly, bam, you hit a pothole. It's a jarring experience, right? Now, the next time you drive the same road, what will you do? You make a conscious effort to avoid that pothole. You anticipate it, steer clear, and navigate around to avoid the damage. And just like the pothole, poor health habits can cause setbacks in a patient's well-being. But with the right guidance and knowledge, patients can make conscious decisions to avoid these potholes in their health journey. It is about building awareness, making informed choices, and ultimately changing behavior for a smoother, healthier road ahead. If we have patients coming back, we can monitor them and what they do, and we can easily help them when they have gone wrong. A study by Alkebert in 2022 indicated an increase in patients who brushed longer, that was from 31% to more than 64%, who use powered brushes from 59% to 85%, who used wood sticks from 41% to 57%, and who used interdental brushes from 40% to 76% during the evaluation phase after non-surgical periodontal therapy. And this highlights the importance of not giving oral hygiene education only once, but maybe twice, 3 times. It is important to consider a patient-centered approach to periodontal disease. Patients with periodontal disease need to be motivated to adopt healthier lifestyle choices and modify risk factors such as smoking and poor diet. Providing patients with thorough information about their disease, treatment options, and oral hygiene instructions promote understanding and engagement. And implementing strategies to improve patient compliance with oral hygiene instructions and enhance self-performed infection control is crucial. I want to show now next how I try to make a difference by providing for my students guidance to better educate their patients. The reasoning behind this is because at the end of the day, I can't go into the communities, but my students do when they do the community service if they do not stay on longer. So if I can empower the students to correctly give health education, I can only hope that it might make a difference in a patient's health that doesn't have adequate access to healthcare. To build a trustful patient-doctor relationship, we need to consider the following: active listening, clear communication, motivational counseling, and the reinforcing of good behaviors. But we must not forget that for patient empowerment and shared responsibility, a partnership between the patient and the doctor is essential. Both parties play a vital role in achieving a successful outcome. Patients are the actors in their own treatment journey. Empowering them to take ownership fosters responsibility and compliance. And by using a person-centered communication skills, including empathy, active listening, and clear explanation, strengthens the doctor-patient bond. So what are our responsibilities? We must not judge or make patients feel guilty about their oral health. We need to consider the patient's overall health and address any underlying medical conditions. We need to involve patients in treatment planning and decision-making to ensure understanding and ownership. And we need to know what we need to know that future research is not yet available on what type of interventions are the best. Is it your cognitive behavioral therapy, motivational interventions? Who to provide these sessions? Dentists, oral hygienists, psychologists, specialists. When to provide these sessions? Is it during, before, after treatment? And then how often? Is one session enough? More often than not, it will not be enough. We need to reinforce good behavior and monitor goals over time. We need to reiterate information and discussions and deal with the setbacks. So again, just to summarize, there is no clear consensus on what I've just mentioned, but maybe going forward, we can actually think about this, maybe conduct studies in this direction to actually see where we can make the most difference. Obviously, another discussion topic is what can we charge for these sessions? And unfortunately, again, I don't have answers for this. I think we as a South African Dental Association can sit and maybe consider additional treatment options where this is then included in more a package deal and not just a single session where we can charge oral hygiene instructions. If we move on to the chemical biofilm, this section will delve into different categories of chemical agents that are used for biofilm control, and also analyze the efficacy of various products and provide recommendations for the adjunctive use in periodontitis management. Chemical biofilm control is an important aspect of periodontal therapy, particularly in patients who are unable to effectively remove supragingival biofilms through mechanical methods alone. So these agents are then divided into antimicrobial agents, which directly kill microorganisms, your plaque-reducing or inhibitory agents that will focus on inhibiting the formation and growth of the biofilm, your anti-plaque agents that targets the biofilm and plaque forming abilities, and then your anti-gingivitis agents, which specifically target the reduction of plaque, which is the primary contributor of gingivitis. The American classification only have then our anti-plaque and anti-gingivitis options. If you come across in the literature, that's the only classification or the categories that they discuss. Now, the first question that was asked, and again, I have put references in, is, and again, for the following statements is recommendations that are put forward in consensus papers. The first question is, what are the adequate oral hygiene practices of periodontitis patients in the different steps of periodontal therapy? Now, it is recommended that the same guidance on oral hygiene practices to control gingival inflammation is enforced through all the steps of periodontal therapy, including the supportive periodontal care. So in essence, a perio patient is a patient for life. The second statement, what is the value of adjunctive antiseptics or chemotherapeutic agents for the management of gingival inflammation? The basis of the management of gingival inflammation is self-performed mechanical removal of the biofilm. Adjunctive measures that includes antiseptics may be considered in specific cases as part of a personalized treatment approach. The third question, should adjunctive chemotherapeutics be recommended for patients in supportive periodontal care? The use of adjunctive antiseptics may be considered in periodontitis patients in supportive periodontal care to help control gingival inflammation in specific cases. The second statement on other agents, we do not know whether other adjunctive agents, these agents include probiotics, prebiotics, anti-inflammatory agents, antioxidants, and micronutrients are effective in controlling gingival inflammation in patients in the supportive periodontal care. So again, there's not enough literature available to support the use of any of these agents. Number 4, which antiseptic is the most effective in dentifrices? If an antiseptic dentifrice formulation is going to be adjunctively used, we suggest products containing chlorhexidine, more than 1% and more, triclosan copolymer, and stannous fluoride sodium hexametaphosphate for the control of gingival inflammation in patients with periodontitis. And then last but not least, which antiseptic is the most effective in mouth rinses? If an antiseptic mouth rinse formulation is going to be adjunctively used, we suggest products containing, again, 1 or more percent of 0.1 and more percent of chlorhexidine, essential oils, and cetylpyridium chloride for the control of gingival inflammation in patients with periodontitis in supportive periodontal care. So that is in essence where we conclude with the chemical biofilm control. If I can just say something quick about antibiotics, this is again a topic on its own. The new consensus is not to prescribe antibiotics unnecessarily. The simple reason being that we have a huge resistance issue And if you read on the World Health Organization website, it states that normal diseases are going to kill us again because there hasn't been an antibiotic developed in more than 30 years. So this is then the study that I referred to earlier that was conducted by one of my students, Dr. Ninka de Roo, where we looked at insights into the preventive oral health practices among patients in South Africa. Now, this study examined the oral health knowledge, attitudes, and practices of 325 participants across Pretoria in a private setting. The respondents were 59.1% female and between the ages of 30 and 39 years old, indicating a focus on working age adults. Nearly half of the respondents had completed tertiary education, and about 60% of the participants had medical aid membership. The knowledge component showed that 55% of participants were aware of dental caries, a common oral health conditions, and 65% knew the cause of dental caries, indicating a good understanding of this issue. 77% identified poor oral hygiene as a cause of gingivitis, demonstrating knowledge of the gum disease, and 57% lacked knowledge about the role of diet and oral health, highlighting an area of improvement. When we look at the practices component, 74.5% of respondents brushed their teeth twice daily, a positive oral hygiene habit. 83% of patients clean their tongues. It's also an often overlooked but important practice. 51% floss regularly, and 69% had received instructions on proper flossing techniques. And then 84.3% agreed that regular dental visits were necessary, indicating a positive attitude toward preventative care. I want to just mention in this slide, with regards to the toothbrushing, although 74.5% of respondents did state that they brush their teeth twice daily, it's not a guarantee that they're in actual fact doing it correctly. When we look at the attitudes component, 79% were willing to teach younger individuals about oral health, showing a commitment to sharing knowledge. This study highlights the importance of preventative oral health practices and addressing knowledge gap. And targeting both individual and community level, oral health interventions could lead to more effective outcomes. So the gaps identified, first of all, a significant gap in participants' understanding of their role in diet and oral health. Despite the awareness of proper flossing techniques, only half of the respondents flossed regularly. And again, it's not a given that they do it correctly. And then addressing these knowledge and practice gaps could lead to more comprehensive oral health outcomes. Yes, with every study, including ours, there were some limitations. First being that the study was conducted in only 6 private dental practices in Pretoria. It may not fully represent a broader population. There was a language restriction as the questionnaire was only available in English. The study's focus on private dental practices may not reflect the oral health knowledge and practices in those in the public health care sector. The voluntary participation could introduce selection bias, as those more interested in oral health have been more likely to participate. And then last but not least, the reliance on self-administered questionnaires may have introduced bias, as participants' self-reported data may not accurately reflect their actual behaviors. So in conclusion, prevention is a key aspect of healthcare, particularly in dentistry. It focuses on proactive measures to maintain oral health and prevent issues from arising. So when we concentrate on positive patient experience, the prevention empowers patients to take ownership of their health, leading to a more proactive approach. Oral health is intrinsically linked to overall well-being, highlighting the importance of preventative measures. Early diagnosis and intervention through prevention can lead to more effective and less invasive treatments. And prevention can significantly reduce the cost of treatment by preventing the development of more serious issues. Prevention fosters a long-term relationship between patient and clinicians, building trust and loyalty, in contrast to curative treatment that often leads to a negative patient experience, potentially causing pain and discomfort. And these patients, it's never your patient. So prevention provides a platform for developing new treatment modalities and advancing dental care. Curative treatment focuses on damage control, limiting the scope of developing new advancements. And prevention has a significant impact on public health, reducing the prevalence of oral diseases. So in summary, I want to show you one of my students' work, or some of my students' work as they work in groups together, in response to the assignment video that I showed earlier.
Hi Dr. Shalom, I'm 20 years old and lately my gums have been bleeding a lot, especially when I brush my teeth. They also feel really swollen and I've noticed some spaces between my teeth that weren't there before.
Hi Hamza, it's good that you came in. I'm sorry to hear that you have been dealing with that. Let's start by talking a bit more about your dental and medical history. Have you had any major dental work before, and how's your overall health? Have you got any medical conditions or are you on any medications?
I haven't had any major dental issues before, just regular checkups. Health-wise, I'm pretty healthy. No major problems or conditions.
Thanks for sharing that. I'm going to look in your mouth and see what is going on. Okay, so from what I can see, it looks like you have a condition called aggressive periodontitis. This is a type of gum disease that can progress quickly and affects the structures supporting your teeth.
Periodontitis? What exactly is that?
Okay, so periodontitis is when the gums and the bone that hold your teeth in place become infected and start to break down. Normally, bacteria in your mouth can be controlled by good brushing and flossing, but with periodontitis, the infection gets deeper under the gums and causes more serious problems, such as the bone being lost, and therefore it will lead to loose teeth.
But how did I get it if I brush my teeth every day?
So even with regular brushing, some people are more at risk due to factors like genetics, where your body's immune response to bacteria is stronger and can actually cause more harm. The bacteria in the plaque can cause inflammation, and over time this can lead to destruction of the bone around your teeth.
That sounds serious. What can I do to treat it?
We'll need to act quickly to prevent further damage. So we will first need to do a deep cleaning, which is known as root planing, where we will remove the plaque and bacteria from below the gum line, as well as the very hard substance known as calculus, using instruments known as curettes. It is also essential that we teach you how to brush your teeth properly, and also for you to floss every day so that we can make sure your mouth is nice and clean.
Is it only about my teeth and gums though, or can it also affect other parts of my body?
Okay, so that's a very important question. So it doesn't just affect your mouth, and it can even affect your whole body, and has been linked to heart disease, diabetes, and even adverse events during pregnancy. This is because the bacteria and inflammation can enter your bloodstream and affect all other organs.
But what if I don't do anything about it? Is it going to get worse?
Yes, so if it is left untreated, it can lead to more serious problems. The infection can cause your teeth to become loose and even fall out because the bone supporting them would be damaged. It can also lead to the more serious health issues beyond your mouth, as I already explained. So we need to start the treatment as soon as possible.
Okay, I didn't realize it was this serious. I will definitely follow your advice. Thank you for explaining it to me.
You're welcome, Hamza. I'm glad that you came in.
So as clinicians and educators, we are but a single ripple in the vast ocean of knowledge. Yet each ripple has the power to create waves. Through my role in educating students, I aim to inspire them, not only impart knowledge to their patients, but to ignite a chain reaction, one that extends far beyond the clinic, touching the lives of others in ways we may never see, but can always hope for. In this way, education becomes not a final destination, but a continuous cycle of growth and influence. I thank you. These are just some acknowledgements, apps, as well as individuals and platforms that made it possible for me to present this lecture to you tonight.
Thank you, Michaela. This was really a fantastic and very important lecture that you gave this evening. I think it is something that is often overlooked in daily practice, the importance of giving proper oral hygiene instruction to empower the patient to be able to maintain good oral health at home when we are not seeing them. So thank you for all the insights you gave this evening. There is a few questions that came up, and if you can allow me, I would like to give the floor back to you for answering those questions. First question that we had was, which essential oils is the most effective in rinses?
Sorry, I didn't go to specific now, but the essential oils, I can get back to you on that specifically. It is in the articles. I didn't go into detail with regards to the specific ones, but I will come back to you on that one.
No problem. And then also, there was a question, is there any new information regarding juvenile periodontitis?
Juvenile periodontitis, I don't think it's something new. We are not referring to periodontitis as aggressive periodontitis anymore, due to the new classification system that we use. The aggressive part, that's one of the mistakes that I indicated to the students, is that they also use the word aggressive. They did away with this term due to the fact that it doesn't really have a role on treatment. So it's more important to consider the stage of the treatment and also then the grading, as the stage refers to the severity and the progression. So, and again, also age is not a determining factor in the new classification, or rather new, it's 2017, 2018. Anymore. So if we diagnose periodontitis when it's present, and depending on the stage, depending on the grade, that will dictate the treatment. If you go to the consensus papers, the treatment is nicely outlined. I actually have a nice QR code for those who are interested. It's the infographic that is available on the EFP website that you can use as reference when providing treatment for patients with periodontitis in the specific stages and grades that you might find them. So ultimately, juvenile, again, you need to consider the cost-benefit ratio if you want to add additional adjunctive chemical agents like, for example, antibiotics. But with regards to new information, it's not new. We know it's there. Yeah, it's not new.
Okay. And then there was another question. Are students still taught chronic and aggressive periodontitis? That classification is outdated. I think you already answered that question.
Yeah, and I just want to, even to confuse the audience maybe a little bit more, I do suspect that it might change again, or there might be changes next year when we have the Euro Perio in Vienna, because an email was sent out to actually ask what are the difficulties with this specific classification. So I do suspect that there will be some changes to the current classification that we use.
Some adjustments. And then there was a question from an anonymous attendee that wanted to know, is a water flosser effective as an interdental cleaning method?
The water flosser, again, it's feel-good medicine. You can't replace, it's not as good as the interdental brushes or floss. So you can't replace it, but you can use it as an adjunct. Yeah, but it's not a replacement tool.
Then there's a question that just popped up. Anonymous said, I spend at least 15 minutes of my 45-minute patient appointment on disclosing instructions, general knowledge, but the medical aides do not want to pay anything towards this. I disclose every visit, not just the first time. Can't our big representatives address this with the medical aides?
Yeah, I think that's what I've also mentioned during the presentation. It is an issue. And if we maybe can address this issue as a association, as an entity, maybe something can come from it, especially with the NHI being the forefront where dentistry is not specified, but maybe this is our opportunity to actually say, this is the package, this is where we should concentrate on if we want to focus on preventative care. And that's the interaction, the education, walking a path with the patient. So yeah, it is something that I know. I'm not in a private setting, but obviously that makes a difference for the patient, for the practitioners, where there's only 30 minutes and now you need to do education, you need to do debridement. So something is going to give, unfortunately, at the end of the day.
I have to say, I know that SASPIO is working closely also with coding and addressing with medical aids and motivating why, for example, oral hygiene instructions are important, but the monetary value that is given for these codes, that is still, I feel, not enough or needs to be improved because it's very important. Then another question that we got was, what's the role of metronidazole currently in the treatment of periodontitis?
Okay, so metronidazole, first of all, is an antibiotic that targets our anaerobic bacteria. So usually periodontal diseases divided into gingivitis, periodontitis, but you also have your necrotizing periodontal diseases. So metronidazole specifically will have an influence with your necrotizing periodontal diseases. Studies do show a synergistic effect when you combine metronidazole with amoxicillin, when you consider it for treatment of really bad cases that suffers from periodontitis. But again, like I've mentioned, we try to not prescribe antibiotics if it's not absolutely necessary. And again, it's an entire lecture or presentation on its own, because when do you prescribe it? The first question. Your dosages, if you look at the literature, it's not the same dosages as in the literature. For how long? So there's a lot of factors we need to consider. And also then, like I said, the whole resistance issue. I've read it was a communication report by Andrea Mombali, also a well-known periodontist in, I think it's from Geneva. We actually said it's so bad these days that countries that are abusing antibiotics, they are the thoughts running in that sense is that those countries can then, when they visit other countries that try to use antibiotics more sparingly, put these countries at risk simply for overprescribing. So that is coming. If we are overprescribing, it is going to shoot us in the foot if we want to travel later on, because it's not only you using the antibiotics, it has a bigger role where it actually influences the entire country. And like I said, if you're going to travel, we're going to have even more problems with regards to resistant organisms.
And Michaela, may I ask, what is your feeling on microbial testing in those cases that is not responding to treatment? or periodontal treatment, if you consider maybe prescribing or going ahead with antibiotics? Is it something you do routinely or not really? Do you see a benefit in microbial testing?
Yeah, microbial testing, Heinz, I actually did a few cases a while back where we were given the opportunity to actually, as part of my education, test the products. But I think they're not in the country anymore, as far as I know. What we did in those instances, it was quite nice. So you use paper points and then you insert it into the deep areas, and based on that, they compile a profile of the microorganisms and also advise on what type of antibiotics will be more ideal. Obviously, we know that the microbial organisms found in periodontitis, it's a lot. We have our red complex, we have our purple complex. So to actually target the microbial organisms would be a much more safer way. Don't get me wrong, there is definitely a place for antibiotics in periodontitis patients. Again, Mombele, when he was here a few years ago, they prescribe antibiotics as a routine, whether it is in the old classification scheme, chronic or aggressive. That was just part of the treatment protocol. But it has shifted since then. And like I said, it does have its place, but we should then prescribe it correctly and responsibly, not prescribing antibiotics before you debride the area. For example, we did touch on the Biofilm where we explained that it is an enclosed community that is protected. So if you're going to prescribe any antiseptic agent, chlorhexidine, antibiotics, it won't have an effect. So you need to do debridement if you consider prescribing antibiotics. So it's small things like that that needs to make you think, and then if you prescribe it, just do it responsibly.
Then how effective is superfloss to minimize gingivitis on patients with orthodontic treatment? Is a water flosser effective in combination with superfloss?
Okay, so again, superfloss, my professor was not a big fan of superfloss. I think, again, you should use the right tool in the correct scenario. So if the superfloss, the thicker part of the floss, is designed to clean around the brackets, not in between the teeth. And again, if you use that floss in between the teeth, it's quite thick floss. So again, like I've mentioned, flossing can help clean interproximally with your mesial and distal line angles. I would stick to, if it is an orthodontic patient, to normal floss, depending on the interproximal spaces between the teeth. Each individual is different. And then also in combination with the interdental brushes. Interdental brushes, it's advisable to maybe consider a large brush for the bigger areas, and then the smallest brush, and use those two just to get the patient used to it in, like I said, combination of floss, as that will then make sure that you clean the line angles, but also then the embrasure space. But superfloss, it's around the brackets. That's my opinion.
Okay. And then what is your view on daily mouth rinses of chemicals, whether herbal or not?
Okay, again, according to the guidelines, it's really not necessary. Yes, you will have your individuals where it might be beneficial, but they are far in between. For example, if you have a patient that has gingivitis and you want to just add a chlorhexidine mouth rinse, yes, you can. And stick to your agents that are mentioned, the triglyceride essential oils, the cetylpyridinium chloride and chlorhexidine, but as an adjunct. It can't replace your mechanical way of cleaning the teeth. Just an interesting fact with regards to chlorhexidine, the studies do show that even if the concentration of the chlorhexidine is below 0.1%, the side effects do not necessarily decrease. So that's also why it's advisable to stick to 0.1%. Obviously, if you go to 0.2%, the side effect profile increase, but a 0.05 will have the same side effects as the 0.1%.
Okay. Then we have another question. Good evening. What's your opinion of laser therapy in periodontal treatment?
Anshan, again, this is a very nice question. On the infographics, it actually asks also or address these questions. So I really want to just share that part of the screen again, where you can just scan the code and you have that whole, I think it's 8-page infographic available. Again, with laser treatment, there's a lot of information out there, but if you look clearly at the specifics, the type of laser, the duration, was the laser therapy done alone versus in combination with a normal mechanical debridement. And ultimately what it boils down to is there's not enough evidence to say that laser treatment alone is superior or the same as mechanical debridement.
And then we have another question. In a setting where you don't have a periodontitis in an area, how far can you go with non-surgical therapy, i.e. scaling, polishing, and root planing or debridement?
Because I'm assuming it's more a patient with gingivitis. Again, if we look at gingivitis, we know it is inflammation of the gingiva, and we usually stick to cleaning above the gingiva, supragingivally. There would be instances where we need to slightly go subgingival if you see calculus. But if we then go on to cases where there's periodontitis, that is pockets 4 and more and attachment loss, we do non-surgical debridement as a rule. That's what we start off with. The reasons being for that is you want to control the inflammation. When you do surgery in a patient that still has a lot of inflammation, it's really difficult. And you can actually do more harm than good. And then with the reevaluation, when there are sites of 6 or more, sometimes 5, it depends on the morphology of the defect, we can intervene surgically, specific sites. But surgical treatment is not a treatment modality for all patients. You will have your indications where patients must be motivated, a plaque index and bleeding index below 15%. So ultimately, not all patients suffering from periodontitis will get to surgical treatment. It's really a treatment modality that is specific for a specific patient, for a specific site.
Yeah. I had a professor that told, a patient needs to earn their surgery.
Exactly.
They can't, show good oral hygiene and reduce the inflammation. You can't expect the surgical therapy to work. Yeah. Then there's a question, regular visits for patients is 6 months after scale and polish. What is the follow-up time for patients with periodontitis after root planing for monitoring and maintenance? Good question.
Yeah, and again, it boils down to the codes and what we can ask. There's a periodontal risk assessment tool that is available freely online. It is Tunetti, I think, is one of the individuals that develop it. So you put in, they ask you specific measures, like for example, how many teeth are lost due to periodontitis, the probing depths, is there any systemic factors that's involved, for that example, and you fill in that form, and according to that risk assessment, it actually tells you what is the recommended follow-up period. Again, the periodontal therapy should be a treatment that is, what I always tell my patient is, it's like having high blood pressure or diabetes. You're going to have it the rest of your life. So it's something that they must first of all understand, but also know that it is going to be a constant monitoring, a constant follow-up. So if we don't do these follow-ups, that is where we can have the disease regression. or recurrence, and where we actually can have a situation where it's much worse off. So I think if one actually discuss this with the patient beforehand and make them part of the treatment, they will understand that even though the medical aids do not cover for it, it is still important. That is just my opinion. I think that is unfortunately where patients need to pay out of their pocket if they do have periodontal disease, specifically periodontitis.
Okay. Then there's another question. In a patient who has periodontitis, if the patient does not respond to normal scaling and polishing, what can you do?
In a patient that doesn't respond to scaling and polishing, okay, and I assume also root planing, okay, so let me go back. Plaque is the cause of periodontitis. So obviously we need to remove the plaque. If the patient is not responding, there must be a reason. Either the patient is not complying and or the cleaning is not done adequately. So obviously when you have a patient that really doesn't respond, what we do in the clinic is we make sure to look at the patient holistically, consider any other medical conditions that might contribute. You know, diabetes mellitus is a big factor playing a role. So that is your thinking, and that's also why I've mentioned it's not just focusing on periodontitis, but it's so much more than that. And also, if you have excluded all other possible causes, then one can actually, then that would be an ideal case to consider antibiotics after your initial course-related phase of treatment. But again, I don't think we should be afraid to ask for help or even feel intimidated. Sometimes it's just something small that maybe I've missed that the next person will pick up. And that is where we can really collaborate and work with each other and also learn from each other.
And then we have another question. What's your view on bone graft success in cases of controlled periodontitis?
We have, okay, so bone graft, with regards to our surgical modalities of treating periodontitis, we have our access flaps where we lift the flap, we clean. Then we have resective treatments where we contour the morphology, especially the bony morphology, to be convex instead of concave, trapping plaque. And then last but not least is the regenerative procedures. So with a bone graft alone, let's go back to the biology. If we understand the disease, we know with periodontitis, it's not only bone that is lost, but also cementum and periodontal ligament. So bone graft, it will work, but the question is, what about the other structures? And that is where your guided tissue regeneration will be a more ideal option, where you make use of a membrane to exclude the epithelium and the connective tissue and allow the periodontal ligament cells, that's the stem cells that actually can provide osteoblasts, cementoblasts, fibroblasts to form bone, cementum, and ligament. And then obviously the use of emdogain is also quite advantageous in these cases. So bone grafts is successful, but again, I was also told to go back to the biology and think, what is the end point? What do you want to achieve? And then it is easy to say whether it will be successful or not.
Okay. And then looks like the final question. If you're in a setting where your patient can't afford periodontal surgery treatment and has very deep pockets, what can you as a normal GP dentist do?
Now that is a tough one. Like I've said, with periodontitis, actually, it's a very, very old article that I've read where they only informed the patients. It was a study population. Obviously, such a study won't be approved by ethics these days, but in the old, they did quite a lot of wild and wondrous studies. where they actually just informed the patient that they had disease, and then they followed them up for over a period of 10 years. And just by informing the patient made a huge difference. So that's what I want to get at. So that's the beauty. It's not a beauty. The periodontitis is a disease, but the beauty of treating periodontitis. You can't do harm by just doing normal cleaning, educating your patient. Obviously, I'm not speaking to surgical treatment that is done sometimes when it should not be done, but that's the thing about periodontitis. You can't do harm. So if a patient can't afford surgery, they're better off than not receiving any treatment at all, ultimately. But I will still get them in a maintenance program. And ultimately, that is the whole aim of that video that my students also made, is the patient must be aware that it's not ideal and what the consequences might be. And if they agree, then it's fine. But yeah, I think just highlighting that we need to communicate with the patient, but also we need to have our records straight, that if the patient does not want to go further or doesn't want to come even for the treatment, we have to have those records to protect ourselves.
Thank you, Michaela. It was really a very good lecture and very informative. And if I judge at the questions we received tonight, you really you tickled the minds of all of our colleagues, and it was really a very good lecture. So thank you very much, Michaela, for your time and all the hard work that went into preparing this presentation.
Awesome. Thank you very much. I'm just going to share the screen quickly for that QR code, if that is fine.
That would be awesome. Thank you.
Okay, is the QR code visible?
Yes.
And just make sure, can someone just confirm that it is working?
Okay. I'm just going to check for you quickly. Yes, it's working. Thank you.
Okay, perfect. And then is there any other, can I maybe just email you the articles for distribution? And then also then I can just come back to the question on the essential oils.
Thank you. We would really appreciate it.
Perfect.
Thank you for everyone for joining tonight. And this has really been a privilege for SASPIO to work with the universities and all the speakers SASPIO and SADA could provide for Oral Health Month. Thank you, and we are very grateful for providing your time and all the effort you guys put in. Okay, good night, everyone. Bye-bye.
Good night.
Thank you. Good night.